So tell us what's going on.
So this is a model of a typical scoliosis. Most children who have scoliosis have what we describe as a right thoracic curve, but there are other curve patterns to scoliosis. Someone can have a curve that goes in the opposite direction in the lower part of the spine, the lumbar spine, or have one in the higher portion of the spine, in the thoracic spine. And scoliosis is not only a curve to the side, but there is a rotational component. So when we look at the spine, there will actually be a rotation here. And that rotation brings the ribs up on one side and depresses them on the other. So although what's apparent when you look at a child's back is the prominence of the ribs, there is actually much more going on inside where there is a curve to the side of the spine.
And it usually goes to the right?
So the typical curve pattern for scoliosis is a curvature to the right, at least in the thoracic spine, and a left lumbar curve. There is, I'm just going to start over again. I don't want to gets kind of too complicated, I think, to kind of try to explain why that might be. But
there is a theory on why.
Well, no good theories. Let's put it that way.
Okay.
It's more of what may be the causes when it's not to the right, I guess. So, but I think that gets But I'll start again. So it's true that the most common kind of curve is a right thoracic curve. So we define that as a curve to the side, to the patient's right side, and that most frequently occurs in the thoracic spine. When we see different curve patterns, some of those do indicate differences that may require other investigation. But fortunately, most children who have a right thoracic curve do not have any other significant associated problems with other organ systems, and we don't have to always investigate those with things like MRIs or other studies.
One more question.
Sure.
How do the kids usually feel about this? Like if they're a little older and they have a better understanding of what's going on, are they worried about what other kids are going to think of them or how they're going to look, and what do you tell them then?
So it's been my experience that a child's reaction to the diagnosis of scoliosis can be quite variable. There are children who were surprised by the information and really do quite well with it. Others may be a little concerned about what does this mean for my activities or my appearance. Unfortunately, most scoliosis, as I mentioned, is not really detectable unless it's really being looked at. And so once children hear that, they can often feel more confident and less concerned about the diagnosis. I can also say that the common forms of scoliosis do not lead to higher risks of spinal cord injuries or other back pain or problems unless they become quite severe or are unusual. So it's not typical for us to restrict a child's functional activities or sports. So another thing that really I think puts children at ease is that this isn't really going to affect their childhood in a significant way, that they're going to be able to continue to do the things that they love to do.
Okay, great. So can you walk us through a treatment, I guess, process? Like what happens from the time the patient first comes in and meets you to what might happen after that? Different possibilities from like the most common to the most complex cases.
Sure. So the process of evaluating a patient with scoliosis and determining treatment differs mostly based on the size of the curvature and the age of the child. Those two factors are significant in determining the risk for the scoliosis to become larger. If a curve is already large, the most common treatment is surgery. If a curve is small and thought to be at risk for progression, then bracing may be needed. And then for most commonly, a lot of curves are detected but are quite small and can simply be monitored.
Good. What does monitoring do?
So monitoring involves determining a duration of time where we would simply continue to allow a child to participate in their usual routine and daily activities, but have frequent enough follow-up where we could detect any changes in the curvature.
We can describe the cases in which we would use a little bit more detail.
Sure.
A brace, how long a child might wear it for, things like that, and then sort of like going to like the rods, which that's what they're called, correct?
Yeah, it's called, what did you say?
What is it? Is it a rod?
Rod,
Or-
yeah, rod.
So I'd start with the brace first and talk a little bit more in detail about like how long to hold child would be wearing that.
Okay.
Okay. So tell us about the different treatment options then.
So treatment for scoliosis is partially dependent on the size of the curve and the risk that we think the curve is of becoming larger. And when it comes to scoliosis that is idiopathic and develops during adolescence, typically curves that are less than 30 degrees will simply be monitored. But curves that are between 30 and 45 degrees often require bracing. This would be a traditional scoliosis brace. And the goal of a brace is to apply forces to the chest, which then are transmitted to the spine, that hold the spine in a straighter position. It does not make a permanent improvement in the curve that exists, but what it can do is slow or prevent a progressive curvature where there is a high likelihood of the curve becoming larger.
And how long might they have to wear the brace?
The brace is worn for scoliosis. Let me start again. A child might have to wear a brace for scoliosis for 2 to 3 years, but the true determinant of our end point where a brace can be stopped is when a child stops growing. So that can vary quite a bit amongst adolescent boys and girls. A girl is typically done growing around age 14. We use a number of different measures to identify the completion of growth. One obvious one would be measuring height with every visit. But we also look at, there are certain bone age markers on the spine x-ray as well as on a hand x-ray that help us determine and predict how much growth remains. And while growth is occurring, a brace is worn. The duration of brace wear on a daily basis varies, but our typical recommendations are somewhere between 18 and 20 hours a day.
I have a question. Is the brace worn underneath clothing, over?
Right.
And do they usually sleep in it too?
So our recommendations for brace wear include 18 hours of wear a day, and that would include sleeping with the brace on. Now the typical brace is an underarm brace that when worn under clothing isn't very visible at all. This brace will be removed usually for physical activities, sports, PE, and often a common wear pattern would be for the child to wear it at night, take it off for bathing, put it on for school, maybe possibly take it off for dance, sport, and then put it on back in the evening to be worn throughout the night.
Let's move on to more complex, like if surgery is required, what that scenario looks like.
What the rods
And
do.
then what, yeah, and what the actual treatment.
Sure.
It's maybe one where we transition to
So
Because I
what
know
we,
that I see rods on the screen, so.
Yeah.
So you can probably describe.
Start
it
with
first.
this and then go to the x-rays?
yeah, all right,
Okay.
so let me, so how are you gonna hold it?
I don't know. I can hold it up. I was going to hold it up next to
That works.
a curved spine here. And maybe I'll put it in my lap. I don't know how much noise that'll be to start with the curved one and then lift it up.
That's fine. You can
Okay.
do that. I'm ready.
Okay, so tell us about treatment for the more complex cases.
So when scoliosis becomes larger than a 50-degree curve, those cases are, let me start again.
All right, hold on.
Sorry.
Take your time.
Yeah. Not all scoliosis requires surgery, but some cases are at risk for progression throughout adult life. So we want to avoid that 55-degree curve that becomes a 95-degree curve over 30 or 40 years. And that's when we generally recommend surgery. Surgery has a number of different goals. One being that we would take a curve, such as this one in this model, and straighten it with instrumentation. Typically, instrumentation involves a series of screws, sometimes hooks, that are placed on the spine, on the back side of the spine, and are engaged with two titanium or cobalt chrome rods that maintain the spine in a straighter position. But they also allow the spine to be fixed in a position that the spine can then become fused. We don't always fuse the entirety of the spine. We selectively fuse and straighten the curved portions of the spine.
So those rods are temporary?
These rods that are placed are not, okay, let me start again. The rods and screws and instrumentation that's placed during scoliosis is not removed later in life. We typically place it with one surgery and then it's left in place for a child's life, childhood and adulthood. Most instrumentation is not detectable, and the reason for that is several. Our spine consists is covered by both muscle, fat, and skin. And as you can see on profile here, the instrumentation is actually lower than our spinous processes. So typically it's not something that's going to be really felt or evident to the eye.
So do you do that after a child is done growing?
Scoliosis surgery can be done most commonly near the end of growth. So for a typical girl with scoliosis, you know, that may happen somewhere in the age between 10 and 16 years old. But there are cases of scoliosis that require surgery at an earlier age. Sometimes surgery must be done in a way to preserve growth. And so in children less than 6 or 7 years old, there are cases where we will implant instrumentation that can be expanded so that it will control the curvature but allow for spinal growth.
And then maybe we can shift to the image and kind of describe what's happening on the screen with this particular case and what happened. Clearly there's instrumentation, so.
Yeah, I think we should, I mean, at least in the information, there's a few things that I want to try to make sure people are going to be looking for.
Okay.
That one would be casting, another would be use of something called the magic rod.
Okay.
Mentioning the EOS system.
Yep.
So, I mean, I know that doesn't need to be
Well, but we're gonna
covered
have to
here.
piece it together, so it's fine if you talk about it, and then we'll pull it all together in post-production. So I wouldn't worry too much about where it falls.
Okay.
So let's talk about, I think we can frame that as there are other treatment modes, and let's just go through each of these.
Okay.
EOS separately I would talk about from a diagnosis standpoint.
Mm-hmm.